against developing post-traumatic responses. We are going through a collective trauma with COVID. So this could not be more timely. If we go on to the next slide, next slide, please. Everybody instantly knows what this is about. Everybody recognizes the pink ribbon as a symbol of breast cancer awareness. I always want to pause and pay tribute to all breast cancer survivors. My mother is a double breast cancer survivor. If you go to the next slide, the reason I bring this up is that according to Susan B. Komen, 1 in 8 adult American women will be diagnosed with breast cancer in their lifetime. Next slide, please. And then go on to the very next one. If we could move ahead 2 slides. As I said, 1 in 8, wrong direction. 1 in 8 American women will experience breast cancer in their lifetime. If we can move forward a couple of slides, the symbol for mental health awareness is much less known. It is a green ribbon. If somebody could advance the slides 2 slides, please. Many of you probably are aware that despite the fact that 1 in 4 American adults will be diagnosed in their lifetime with a mental health disorder, many fewer of us recognize those, many fewer people recognize we're not as a community, we're not as literate in behavioral health. Thank you. If you go on to the next, as I was saying, 1 in 4 Americans is diagnosable with mental, thank you, you can go on to the next one. The reason we are not, thank you, the reason we are not, I think, as aware of mental health issues as a community, that we don't know what the symbol for mental health awareness is because of stigma. Stigma, the word we all know has Greek origins and means to mark or to brand. In the Christian tradition, it's also used to refer to the marks of the wounds of the crucified Christ. Stigma prevents open discourse and results in our behavioral health literacy remaining low. It creates fear, rejection, avoidance of people with symptoms. It leads to very real discrimination and disenfranchisement in terms of access to housing, access to jobs, other kinds of social determinants of health. And shame associated with stigma leads people to conceal symptoms, delay, or even refuse treatment when it's available. Next slide. We could go to, thank you. I started a couple of years ago making a habit of acknowledging my own personal struggle with chronic low-grade depression. I have probably all my life, certainly for the last probably 25 years, recognized that I live with depression and actually have been greatly helped by psychotherapy, talk therapy, as well as by antidepressant medication, antidepressants like Prozac. I raise this because in my own life, it highlights a story, it provides a vignette about stigma and about our low literacy rate. If you go to the next slide, let me just say that my depression was never such that I couldn't get out of bed and go to work every day. But truly all of the color was bled out of my life. Color in terms of emotional richness and interpersonal connection and so forth. If we can go to the next slide, there is a TED Talk that was was given by a teenager who experienced depression. Again, if you could advance the slide. This is a picture from that TED Talk. This teen said quite poignantly that depression is not about being sad when something is wrong. Depression is about being sad when everything is right. And that was the dilemma that I had. I looked around, nothing in my life explained the way I was feeling. Because I was living with depression, I was feeling sad all the time. I was not feeling enlivened and animated and engaged. Depression is about being sad when everything is right. And I couldn't understand what was wrong with me. How could I be so unhappy when I had so much? If you go to the next slide, please. A couple of years, I really struggled with the decision to try an antidepressant. If you go to the next slide, I happened to mention to one of my uncles, and let me just back up and say, you know, when I was struggling with that decision about seeking treatment for depression, I knew about my family's health history. I knew about my grandfather's pacemaker. I knew about colon cancer and skin cancers, and I knew about any number of diabetic disease and heart disease conditions and so forth throughout my family. A couple of years after I started taking Prozac and mentioned it sort of offhandedly to my maternal uncle, he said, "Oh, you of course know about grandma, right?" If you go to the next slide, please. I didn't know what he was talking about when he mentioned grandma. I didn't know about grandma. Well, my grandmother actually had been hospitalized multiple times for depression and indeed had been treated with ECT, electroconvulsive therapy, which at the time was really a sledgehammer. It was a very scary thing for people that were not responding to anything else, and there were very few options at that time. So upon learning that my grandmother had been so debilitated by depression, I was initially angry that nobody told me. And then I realized, of course, I also didn't ask. If I had been experiencing heart symptoms, or if I had diabetes, or if I had some other condition, I would freely have asked the family, hey, anybody been treated for this and what worked and so forth. But even in my profession and even in my commitment to behavioral health, I did not ask. I did not say to anyone in my family, in my extended family, hey, I think I'm depressed. And I'd like to know if there's depression in the family and what worked and so forth. Because we do not talk about mental health and behavioral health challenges in the same way that we talk about physical, somatic health. And we need to. Next slide, please. Similarly, you know, if my son went to camp and came home with a broken arm like this is not my son, but looks sort of like my youngest son. If he came back from camp with a broken arm like this, we'd be walking around with a Sharpie and having everybody draw on it and sign it, and we'd be bragging about our brave young boy. On the other hand, if our son came back from camp and had experienced trauma secondary to separation, developed school phobia, school avoidance because of that anxiety, because of that trauma, it's far less likely that we would be speaking openly and out loud about that. Why is that? Next slide. Again, I'm beating this drum. It's about stigma. And if we go ahead to the next slide again, one of the biggest concerns about this is that these are brain-based disorders. I'm going to move very quickly through these. These are images, brain images. On this slide, two different pairs of images looking at scans of individuals' brains who have post-traumatic stress disorder or not. The ones on the left are negative. The ones on the right are positive. You can see very, very different patterns of activity. This is metabolism and electrical activity. Next slide. That was post-traumatic stress. And the next slide, you can see, look at the differences, structural differences in the brains of a well twin versus a twin diagnosed with schizophrenia. In the lower right, you see images of someone who has been diagnosed with depression compared to someone's brain scan that is not depressed. These are brain-based disorders and belong squarely in any conversation about healthcare. There isn't just behavioral healthcare and real healthcare. Behavioral healthcare is real healthcare. Go on to the next. There are a couple of slides of individuals experiencing drug addiction. Again, you see very dramatic functional differences and changes in brain, some of which in all of these conditions are reversible and some are not, frankly. If you go to the next slide, let's go ahead. I'm getting low on time. A couple of things I just want to say about all of this. First of all, it can happen to anybody. And if you go to the next slide, some of you may remember this story that was covered in the Washington Post 5 years ago. This was a homeless man that was arrested downtown for disturbing the peace or for trespassing while he was at a bank waiting for his monthly stipend and refused to leave. He was talking to himself, scaring people, living on the streets, and so not clean. He was smelly. When he went to court, the judge started to explain to him, because he didn't have representation, how the proceedings would unfold. And he said, "Yes, sir, I know. I went to Harvard Law School." And people in the audience sort of whispered in disbelief until the judge looked out into the courtroom over his glasses and said, "Yes, sir, me too. I remember you." The judge and this gentleman were both Harvard Law classmates of our Chief Justice, John Roberts. It can happen to anybody, and I would love to tell you more about that story, but I want to move quickly to my last remarks. Going to the next slide. It can happen to anybody, and the next slide, going the other way, I want to just say that treatment works. One of the reasons that, or one of the tragedies of stigma, delaying people to, leading people to delay seeking treatment, is there's a 6-year delay between onset of psychotic symptoms and when people get engaged consistently in appropriate antipsychotic treatment and cognitive behavioral treatment and so forth. During that 6-year delay, lives are destroyed. Relationships are destroyed. Educational and career paths are knocked off course. But treatment works. And if we get people the right care at the right time, treatment works. And this image is of Pete Early on the right and his son Kevin Early on the left. Kevin first exhibited symptoms of serious mental illness during college, and Pete Early, who was formerly a Washington Post writer and is a Pulitzer Prize nominated author, wrote a book about his family's journey. Kevin, I'm happy to report today, is employed full-time as a peer specialist on an ACT team in Fairfax County, supports himself in an apartment and lives a very full life, participating in family life as an uncle and son and brother. Treatment works. If you just go ahead and advance slides to the end, I'll wrap up. I don't have time to really talk about trauma, but anybody that's not familiar with the body of work around adverse childhood experiences and the power, if you can pause there for just 1 second, back up. The power of just looking at exposure to different kinds of adverse childhood experiences, trauma in childhood, being one of the most powerful powerful predictors of adult chronic illness, physical illness, and even early death, it reinforces what I was saying, that there is no, it isn't behavioral health care and real health care. Behavioral health is at the center of health care and of wellness. There are a number of things that I will yield the floor, but there are a number of things that the department is doing right now to shore up behavioral health supports to people, our traditional population, the public safety net. But we are also aggressively pursuing SAMHSA funding and other federal funding to enhance, augment behavioral health supports that are available to people who are less ill than SMI, including to address the behavioral health impacts of COVID on healthcare professionals. So I hope you will stay tuned. I'm eager to hear my fellow panelists, so I will stop there. I have asked the Prestige team to circulate these slides because there are some references. There is a video link. There are some tips about how to talk to children about the COVID crisis, and then these resources that hopefully everyone is aware of, both from the Department of Behavioral Health and elsewhere. Again, thank you so much for the opportunity, and thank you for your leadership, Prestige, and Mr. Washington and team in hosting these events over the next 3 days. Thanks so much.
Dr. Bibal, you are quite welcome. We appreciate your very insightful and revealing opening remarks. One of the key takeaways that we certainly will hold on to is that behavioral health is central to the essence of all healthcare. And thank you for that very poignant insight. We're going to just remind, as you may have seen come across the screen, that we'd like for everyone on the call today to send your questions via the chat, and so that we will have a Q&A session later on in the presentation. And but don't wait until that time to send your questions. Go ahead and put them in the chat as you think of them. Also, we are broadcasting live now via Facebook. So we continue now with the Prestige Community Resources and in the DC Department of Behavioral Health, Mental Health Wellness, Mental Health Awareness event. And this is a 3-day wraparound, and we're going to continue with some very poignant insight coming to you through our next speaker. And she is Dr. Masika Jordan. And Dr. Jordan comes to us as a graduate of the University of Maryland with a BS in sociology back in 2005, and with also an MA in counseling psychology. Thereafter, she completed a doctorate of education in counseling and psychology in the year 2010. She is a licensed clinical professional counselor, LCPC, and a certified peer recovery specialist. In addition to her formal education, Dr. Jordan has lived her real experience as a peer in the recovery community, having overcome substance abuse herself, as well as having experienced it through other family members as well. She has turned her pain into passion and is motivated to improve recovery for all through building the Jordan Peer Recovery, and she is here to talk about all of that today. We welcome to the conversation Dr. Masika Jordan.
Thank you, thank you, thank you. I am excited to share with you all today, especially during this time. If we could bring up the slides, thank you. What I want to discuss, while I'm a professor and I sometimes move into that academic setting, I really want to have a conversation with you all today. So there'll be times during this time that I'm with you that I'll ask you to send a response into the chat box, just to keep this interactive and to get the most out of this presentation that I think and I hope it will actually benefit many of you, either personally or either people that you're working with or family members, clients, et cetera, et cetera, et cetera. So this is a presentation that I've done for the second time. I actually did it with some students at Bowie State University, because when the university shut down across the globe, the students were impacted, and they were demonstrating it through academia. So we could look at the data and see that the grades were declining and things of that nature. And we had to figure out, how do we support students? But the same conversation needed to take place in the recovery community. So how do you support people that are in long-term recovery, and not just recovery from substance abuse, and not just in recovery from substance use disorders, and not just in recovery from trauma, and not just in recovery from, and you can fill in the blank. And actually, if you would take a moment and just pull up your chat box and type in one thing that people can be in recovery from, because you can be in recovery from lots of things. I've talked to people right now that are in recovery from grief and loss. And whenever we have a conversation that is about recovery, we have to talk about mental stamina. And how do we strengthen mental stamina so that we don't experience the breakdowns and the relapses that come with the additional stressors that come with coronavirus during this time. Yes, I see childhood trauma. I see childhood adversity, recovery from codependency. Yes, that's very real. Recovery from neglect, recovery from illnesses. Yes, there's there's recovery communities for loneliness, recovery communities for, you name it, finding loss of a job, and then that's an intangible loss. Recovery from low self-esteem and feeling less than. So I want to talk about this presentation that I'll go through. I want to be able to take these tools and actually have them be applicable. And whatever you type today is a type of recovery. I want you to look at it as a foundation. So these may be things that we do on a regular basis, but now it's time to strengthen it. So COVID-19 and the impact on mental health. We have had reportedly 100,000 people die in the United States of America in this short period of time. Coronavirus didn't really hit us until somewhere around end of February, March, where you really started to see the spikes. So you're talking about, in a very brief amount of time, 100,000 people have died. And we haven't even experienced the spike yet. So when we talk about death, the U.S. has experienced trauma before, but not like this. The U.S. has experienced trauma with 9/11, and I had a friend that actually was on a plane in 9/11, and I know the impact personally. But we've experienced traumas, but not in this regard. We have never had places or times where we've had to stack skating rings with people that are deceased. And these are not just numbers. These are people that we love, we have connections with, that are staples in our community, stakeholders in our community. So when we talk about grief and loss and we talk about trauma, you're also talking about some of the other things that come with that. So you're talking about released stress levels. You're talking about dietary changes that impact, because sometimes people self-medicate and they do it with food. Sometimes people self-medicate and they do it with substances. So now you're seeing a spike in suicide ideation. You're seeing spikes in suicide rates. And while the American Psychological Association has not been able to pinpoint at this point whether the spikes are contributed directly from COVID-19 or whether we're seeing an influx in other from other triggers, it's likely and it's probable that we're experiencing this high rate of suicide because of COVID-19, because of the trauma that comes with it. So I want to talk about, how do we address that? How do we address that personally? And if you would for a moment in the chat box, just, there's this Me Too movement, and I was a part of that Me Too movement as well. But I want you to type in the box one thing that has personally been a detriment to you personally, not something that you've heard about, but something you have directly experienced as a result of COVID-19. death of a loved one, loss of feeling isolated, loss of several coworkers, anxiety, insomnia. Class of 2020, people weren't able to graduate. Those are monumental peak in moments for people that have been in school for 12 years. High anxiety in the grocery store. Yeah, you can't even go grocery shopping without feeling anxious to some extent. Medical neglect, scared to attend appointments because you don't know if it's risk, you're taking a risk, a life, death in risk to do it. People have caught COVID-19 and feeling isolated, frustrated, afraid, fearful. These are things that if you look at some of the signs and symptoms that you're typing up, death of parents, I'm sorry for your loss. Yeah, the cardiac problems that are indirectly related to stress indicators. Yeah. When we see lifestyle diseases, when we talk about lifestyle diseases, those are things like diabetes, hypertension. If you look at those things are even cancers. There are some cancers that if you do the research on it, you can refer to Dr. Caroline Leaf. She was a neuropsychologist, really prevalent in this time frame. She said that 80% of lifestyle diseases are related to stress. So what's going to be the aftermath of this COVID-19 if we don't do some proactive measures on mental health? Some of the stuff that you typed were signs and symptoms of impact on mental health. I saw people type denial, anxiety, fear. We have guilt, shame. You know, when someone is dying in a hospital and you can't go see them, and that's your mother or your sister or your brother or your loved one or a friend, and you can't go see them because you're not allowed, or someone's having a baby, which is just a celebratory event, but you can't go with them to be with them in that moment, and they have to be by themselves. Those are things that have lasting impact, even beyond this crisis moment. Feeling like you're alone and you can't see your grandchildren if the person when people have COVID-19, they're kind of isolated, almost locked in, if you will. And while we call it quarantine, it feels like you're locked up. If we're going to be transparent about it, it feels like you're being put away for something that you did and you didn't do anything. So I want to talk about all of this and umbrella it under this is trauma. So what do we do with that? Some of the things we end up doing when we don't do anything with it: nightmares, visual images of the event, loss of memory, disorientation, confusion, mood swings. When COVID-19 first hit, I asked a bunch of professors that were in the counseling psychology department with me at Bowie State University, and I asked them, tell me if you gave me one or two words, tell me what it feels like right now. And they said, we're feeling like we're in a dream. It wasn't a good dream. They felt like they were this is disbelief. Like this happens in movies. This doesn't happen in real life, but it was happening, and it is happening in real life. So you can go to the next slide. Thanks. Impact on family systems and health and well-being. There has been, and I know someone else is presenting later on, if you can go back to one slide. The impact on family health and well-being. I am a mother, a business owner. I've worked full-time as a professor, and I own a business, and I sit on different organizations, and all of that never stopped when COVID-19 hit, including my 6 and 7-year-old. And anyone that has children in here, if you would type me too in the chat box. I had to become a teacher, K through 12 teacher. Now I can teach college students and graduate students. They don't require behavior management, but my children require behavior management, and so did yours will. And so we had to become these things overnight and shift, which also you can see is an indirect stress measure. So when we start to look at all of the implications of 7th grade teacher in 2nd grade, look at all of this. You have to do that overnight. When you look at all of this and you umbrella it under COVID-19 impact on family health and well-being, you're going to see spikes in domestic violence for people that are not otherwise getting resources that they need, because most of the resources are now closed. You're going to see that in COVID-19, where people used to be able to go get supports for stressors and anger management issues, those places are closed. While some people have adapted to the virtual technology, virtual services, not everyone and not every organization has just yet. And they need time to manage that change process. But in the interim, AA meetings are closed. The ones that were in churches, the NA meetings that were the Celebrate Recovery meetings are closed. The anger management sessions, the Roberta's houses in Baltimore for people that experience traumatic grief, they're closed. So what do you do with that? We can move on to the next slide. Strategies to deal with anxiety and fear. Here's some couple of techniques that, and again, these things can be useful at any given time, but especially right now, because most of what I'm going to discuss today, you can do in your home by yourself. Whether you're virtually able to get counseling or not, you can do these things and implement them yourself. If you're working with clients, these are tools when they're not in your presence or virtually connected to you that you can give them as homework, as resources. These are resources that if your family members are struggling, you can use them with them. And these are even resources that I have used with my 6 and 7-year-olds to give them stress management techniques while they're having to adjust to a new reality. So mindfulness meditation. I'm going to put this in 2 spaces. So mindfulness meditation, you really can just sit with if you would take an object, if you would take a word, and this is one of the quickest techniques you can do. If you take a word like a rainbow, take a word like peace, take a word like water, and you can take anything that is a visual, that creates a visual imagery for you, and take that word, close your eyes and imagine it. Sit with it. And when and don't be shocked that other distracting thoughts are going to come up during the time that you're sitting with it. But your job is to kind of, when the distracting thought comes in, bat it away, go back to refocus on my rainbow. What it's going to do is going to create a euphoria. It's also going to increase the endorphins that are released in your brain, which is the same thing that happens when you take psychotropic medications for depression. Not at the same level, but the intent of psychotropic medications for depression is to increase endorphins. You're going to increase endorphins through mindfulness meditation, and you don't have to have done this for 20 years to be able to implement it. Art therapy. So, while art therapy in an office with a licensed clinician is great, you may not be able to do that right now. But you really can order an adult coloring book off of Amazon. You really can, if you don't want to order it from Amazon, get your printer and Google adult coloring sheets and print those out. You can do the same thing for your clients. You can do the same things for your kids. My daughter loves to color, so we actually schedule in time. While the schools have required that they do X number, the workload has been tremendous, tremendous. But I have said, no, you're not going to work like slaves. You're going to stop and you're going to take a break and you're going to color, because my daughter loves to color. My son loves the technology. You're going to stop and you're going to be able to create. And my son, who loves the tech pieces, there are actually some online coloring books that you can use as well, that you can color by number digitally. Cognitive behavior therapy. I kind of want to shift this to metacognition, for the CBT. Yeah, good. I'm glad you started coloring. I want to switch this to, instead of CBT, so CBT is really you think, you feel, you act. So you can say that out loud wherever you are. We think, we feel, we act. 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 That is CBT in a nutshell. What you can do, though, with metacognition is think about what you're thinking about. So be conscious when you see the death rates going up. If you're thinking about that for 20 minutes, it's time for you to think about something else. Literally, you can program your mind to switch the channel just like you use a remote control. So if I take a remote control, I wish I had a remote down here, but if you take a remote control and you can switch the channel, you can do the same thing in your mind. It's called metacognition. You get to switch what's being programmed in your mind. Also, some things to assist with that. If you're a Facebooker and everybody that you're following on Facebook is talking about everything that's dire, and take a break from Facebook or either change who you're following. If you're watching the news all day, every day, I know we need to be current and keep up to date with current events, but you don't need to watch it for 3 hours. Figure out something to do. I like Shark Tank. I like TED Talks. I subscribe to audiobooks. Those are things that'll help you with the metacognition process, because the more you feed your mind with other stuff, you're going to think about it when you're not even intending to, because it's like background noise, if you will, that resurfaces even when you're quiet. So if I can flood my mind with positive things, then it will allow me to practice metacognition in an easier and manage that change process of what I'm thinking a lot easier. Make sense? You can go to the next slide. Identifying your triggers. If you hear quick pieces, I've heard from students, I've heard from clients, I've heard from peers, some of their triggers have been TV. Some of their triggers have been workloads have increased. So while some people have been laid off, but there's some people that are working virtually, and while you used to be able to stop your day at 5 o'clock and clock out and go home, you're not able to do that anymore. So you have to set boundary lines for you so that when these triggers come up to stress, you can do something with them. Coping skills. If I know my triggers are, especially if we're talking about in the relapse arena, if we're talking about I feel stressed, I feel, some of your triggers may be body responses. You may feel increased heart rate. You could feel sweaty palms. You could feel like you're having a headache. When those triggers, you be conscious and aware, start to journal those triggers so you can figure out what they are for you if you don't know what they are already. And when you see them, then what your job is to do as the manager of your mind is to then insert a coping skill. I'll talk about the cognitive triangles just a tad bit. If you have a triggering event, increase your coping skill, do it again until you can start to see a change in the intensity. Does it make sense? Thoughts, feelings, behaviors. We just talked about that. That's CBT. You can go to the next slide. Strategies to deal with stress. Strategies to deal with stress. You can go to the next page. So strategies to deal with stress. Thank you. So I want you, when you think about stress, a lot of times people just think about addressing stress from a singular approach. Like, okay, I'm going to change the way the amount of activities I'm doing. Well, that's only one dimension. When you think about changing the amount of stress you have, especially during this type of climate, you want to look at the self-care wheel. So I can make this slide available and make sure that everyone has it. If I can send it to you, well, for everyone to have a copy of it.
If you send it to me, I'll make sure that anybody's email address that's in the chat group and anybody that registered gets it.
Perfect, thank you. Use this as an assessment. What I have clients do is every section on here. So for example, you'll see under psychological, you'll see self-reflection, therapy, journaling. Color the percentage in that wheel that you're doing a regular job of doing that. And I would use this as every 5 days. Every 5 days, I would do a personal check-in, especially during these high stressful times, to color in my grid. So then I may have physical, I may do a great job, and I may have all of that kind of circled, or colored in. Like I may have that completely colored in. But then on another section, like spiritual, I may have 20% of that colored in. And spiritual does not mean that you have to have a specific religion. Atheists are spiritual. So you can pick whatever works for you and make that work for you. But there should be some level that you're circling in for each one. And where you notice that there are lacks or gaps, or that you notice that, hey, I'm only really doing like 10% over here in this self-care wheel, then your challenge and your homework for yourself to take better care of yourself is to then actually that week focus on building that up so that you can have an even wheel. If we think about a wheel on the car, if a part of the wheel is missing some air, we don't drive anywhere. Well, such is the same with the self-care wheel. If you're missing or you're flat in one area, it's going to impact you, period. Okay, you can go to the next slide. Hierarchy of needs. I'll talk about this kind of briefly. We've all heard the Maslow's hierarchy of needs, what they are. But there's some things that because of COVID-19 that have been impacted. For example, being able to be attached or belong to a group. Just because I'm socially separated doesn't mean I need to be socially isolated. So find some social support groups that you can connect to that you're able to gain some positive energy from. I don't know what happened to the slide. It kind of went away. I think the slides went off.
I think they're working on it.
Okay, I can keep going. It's I know it's at the end of it. I still have it here. So once you do the self-care role, your job is to kind of do some self-care, to actually take whatever you're lacking in, insert it, do it, and make it stronger for yourself. What I want to talk about is also community resources. So just because in the Maslow's hierarchy of needs, if you cannot connect physically to someone, even if you were someone experiencing COVID-19, there's actually groups that are creating online platforms for people that are experiencing different levels of illnesses with COVID-19 and different levels of impact. Join and connect to those groups. That's the value of peer support. Samsha said that And there's been a lot of other research studies that have said that peer support in general, not just with addiction, but peer support in general has been found to be one of the strongest interventions for people with SUD, substance use disorders, lived experiences with substance use disorders, is it right along with medical assisted treatment. So if we think about it in that regard, it has implications across the board. So you can get peer support from having someone else who has a shared experience with you with COVID-19. You can get peer support from someone else who's lost a loved one during this COVID-19. You can get peer support in several different ways, but your job is to make sure that you're connecting with the community. You can, and I want to park it here, and I'll probably just end with this piece. So if you're working with other people that are in treatment and recovery and they need support, make sure that during this, even if you're a medical professional, whatever your job is, if you're helping someone else, if you're a clergy member, if you're helping someone else, there's some things that you should do to make sure that what you're delivering is culturally responsive. Some of the reasons why we've seen this spike in where you've had more minorities impacted from COVID-19 in certain areas in certain states as opposed to other people and other groups is not because African Americans don't take care of themselves. It's not because Hispanics don't take care of themselves. It's because sometimes there's gaps in the system and the systems aren't always culturally responsive. So some ways that we can increase cultural responsiveness, and if I'm a person receiving services and I happen to be, and I am African American, when I go get services, there's some things that I should require of my provider. And so this JPR's ACTS model, Jordan Peer Recovery, we built this 2015. We responded to Freddie Gray riots. We've responded to the heroin addiction in Baltimore and across the world at this point. We've built this culturally responsive model for peer recovery, but I think it has implications here, and that's why I'm sharing it. You can go to the next slide. And so there's some things that you should ask your provider. Who are you? And the person that's receiving services, who are you? What do you need? How are we speaking the same language? Are there things that I'm saying that you're not quite getting? Or if I'm the person giving services, that I fully understand you? So paraphrasing and restating so that I understand that there's not a gap in what you're expressing to me. It's not that we're speaking two different languages, we're speaking two different cultures. And so some of those things are very subtle, but if you don't pay attention to the subtle things, it's almost like not paying attention to the splint in your finger. It's going to cause pain, and it's going to cause people to be overlooked. Also, challenge yourself. What biases do you have? If I'm a person issuing or delivering services, do I have some inherent biases? And if we were in a room, I would say everyone that has a bias, raise your hand. And I would expect 100% of people to raise their hands because most people have a bias. And if you say you don't, I would challenge you just to look a little bit deeper, because most of us, whether we intended to have one or not, it's behavioral and cognitive. We've learned it from somewhere else. It is racism and bias is not the same thing. Bias is a preference. And so how we navigate that when we're providing resources for people that are in recovery, or when we're getting resources, do I go to the best doctor, or do I go to the doctor that I feel like I have more in common with because of the complexion? Maybe not. Maybe I should go to the person that I'm more uncomfortable with if the person has better services. Or if I'm a person delivering services, do I assume that everyone that comes in my office needs the same type of resources because this is what I need? No, let's not make those assumptions. Let's ask. That's the gist of the model. I don't have time to go too much in detail on the ACTS model, but those are just some suggestions, highlights from the model. You can go to the last slide. And I can, when we share this, I can get us to Will too, but I did talk to Mr. Bonet today or last week and mentioned that anyone that wants to be a part of the JPR CAP conference is more than welcome to come. That presentation will go more over substance use disorders and how we respond in the peer recovery format. And I think last year we had like 500 people in attendance. This year it's virtual, of course, but our numbers are looking quite about the same. And so if you want to be a part of it, we're doing it because we partner with Prestige. We want to make sure that anyone that is a part of their Prestige community is able to attend for free. So I would have to issue you a special code. Otherwise, the tickets are like $55 or something. But anyone that comes through Prestige, anyone that's here, you're welcome to attend for free. that's all I have for today. And I hope this information has been engaging and helpful, and it's stuff that you can take away and apply in your own life, as well as with any clients you work with or with your family members, friends, etc.
Dr. Masika Jordan, we are so pleased to receive all your insights today, as well as the host of resources that you provided, including your self-care wheel, along with the peer questions. I already see some people putting requests in to receive the peer wheel from the chat. So again, thank you so much for your timely and poignant information. And we're going to have some more speakers coming, but right now, we have coming to us Mr. Wilhelm Bonnet, Will Bonnet. He is the Business Development Manager here at Prestige Community Resources, and he's going to talk to us a little bit about the phone survey and presentation. So please, Mr. Bonnet, we welcome you.
Okay, it looks like my picture's frozen here. I'm assuming everybody can hear me. I am actually the president of Prestige Community Resources. And while we're waiting for the PowerPoint to come up, I just want to emphasize the importance of doing this symposium. I want to thank all the speakers that have so far presented, but the ones that will be presenting as we move forward. And really the theme of the symposium is, developing resilience in our community. We are facing a lot. Dr. Jordan did a great job of talking about some of the things that have impacted us personally across the board. But to take it a step further, we have another pandemic that's probably going to come the next flu season. And we have to prepare our community. We have to be resilient. We have to find common areas where we can help each other, because nobody's going to get through this alone. And even more importantly, I just want to emphasize the importance of staying connected, which is what we're trying to do with our phone drive. This is the first slide? There we go. Okay. Could you go? The Prestige phone drive is something we've done before, and what we want to do is supply phones with plans that will support staying connected to healthcare. We've given out over 100 phones last year. So far this year, we've given out 85 phones. Our phones come with a service plan that includes unlimited text, talk, and data. So it's not like the Obama phone or the Medicaid phone that you may run out of minutes within the first week. I want to be able to see the entire slide. Connection is a rare commodity for most people that are homeless. We have had people that have not had a phone for years. Now that we've moved, because of the pandemic, to using Zoom or using technology to be able to connect with our consumers, we have to ensure that our consumers have access to that technology as well. Otherwise, the outcomes are going to be negatively impacted. This is true when it comes to things as simple as passing a conversation or eye contact. Providing an outlet, we aim to reconnect these individuals to support. We train all of our staff, to, when we give out the phones, to upload them with Zoom and train their CSW, their consumers, to be able to connect to people. Phones can increase emergency response ratings by 98%. On the streets, healthcare and healthy lifestyles are next to impossible, which can create health emergencies in the blink of an eye. If you doubt that, go visit some of the shelters that provide services for the consumers that we work with. And I guarantee you, you won't spend the night there, because you're more, inclined to take care of self, and you have resources. These people do not, and we cannot leave people behind. Could you go to the next slide, please? Our latest initiative is dedicated to expanding that focus to the homeless community, an underserved demographic that has been limited to no ability to engage with desperately needed essential services, such as calling 911, medical facilities, and critical organizations. In partnership with AT&T, we have developed a program to give these individuals a lifeline to essential services by providing cell phone usage to over 500 individuals in need. We need your help to make this happen. A small donation, $30 a month, or one-time donation of $360 will cover the person's phone and services for a year. It's not difficult. I don't know about you, but $30 is not going to make a whole huge difference in my standard of living. And if I know that I'm able to help someone, that could be my brother, that could be me. I would want someone to help me if I were in that position. Next slide, please. Community. I'm one of those people that actually contracted COVID, and I had to make a decision. Am I going to let this kill me? I'm going to have to participate in life. And the reality is, if I take personal responsibility for my health and community, I've come to the realization that I cannot allow this pandemic to stop me from living life. And I have to, for my community, for my family, for my personal health. I have to do whatever I can do, find the solutions to be able to stay connected, okay? And our consumers.
Do you know?
I'm sorry, go ahead. It's your turn to save a life. Text a life to 202-938-2824. It'll take you to a donation site. If you have PayPal, you can opt to have the donation go in once a month. And at the end of the year, you'll have a sizable tax write-off. Prestige Community Resources is a nonprofit, so we look to the community to help support some of the services that our consumers desperately need. Now we can move on to the next. I'm gonna turn it back over to Seth.
Thank you very much, Will Bonnet, President of Prestige Community Resources, sharing some very good insights. And please remember that number there, 202-938-2824, one word, save a life, text, please. And we have coming up now to talk to us today and during the conversation about domestic violence. And we have members representing the DC Office of Rehabilitation and Development, beginning with Edward McCurdy. His credentials are listed as LICSW and LCSW-C. Edward McCurdy has worked as a human services professional in Washington, DC for the past 18 years. He earned a BA in history from the University of Maryland at College Park and his MSW degree from Howard University. From June 2012 through June 2018, he was employed as a forensic social worker in the DC Office of Rehabilitation and Development at the Public Defender Service for the District of Columbia. Since 2014, he has operated a private therapy practice where he maintains an office and sees adolescents, families, and adults. He has received advanced training and specializes in treating anxiety, depression, developmental trauma, grief, and loss. And that is Mr. Edward McCurdy. And also, who will be joining with him is the Chief of the DC Office of Rehabilitation and Development, Betsy Bybin, LICSW. Betsy Bybin is a forensic and clinical social worker Betsy Bobbin is the chief of the DC Office of Rehabilitation and Development, where she has served her clients and public since 1982. She's dedicated her life to empowering people arrested in the criminal and juvenile justice systems. Throughout her career, she has prepared sentencing reports or testimony before the courts in Washington, D.C., local and federal, Maryland, Virginia, North Carolina, Georgia, Alabama, and has trained judges, attorneys, and law and social work students on a national and local basis since 1976. She's a member of the Defender Council and the Client Policy Group and a founding member of the National Alliance for Sentencing Alternatives and Mitigation Specialists for the National Legal Aid and Defender Association. She also serves as a board member for the Southern Center for Human Rights and Voices for a Second Chance in DC. She's also a former consultant for the Sentencing Project and the National Center on Institutions and Alternatives, NCIA. She has worked in the criminal justice system since 1974. We welcome to the conversation now Edward McCurdy and Betsy Bobbin.
Good afternoon, everyone. Edward McCurdy is actually going to start the presentation and be the primary presenter. And then after a bit, we'll have a conversation about this subject. I need to say that I am not speaking as a public defender from the Public Defender Service. I am speaking independently. Thank you. Ed?
Good afternoon, everyone, and thank you for this opportunity to share information regarding this important topic. And so, we know that our society, prior to the COVID-19 pandemic, was experiencing an epidemic of intimate partner violence and other forms of family violence. That epidemic is long-standing in our society and in our culture. And so, the onset of this pandemic naturally will lead to a serious uptake and increase in the number of intimate partner violence incidents in homes across this country and across all demographics, across racial demographics, economic demographics, cultural demographics, geographic demographics. There's no space within our society where this dynamic won't be present. So first, I just want to talk a little bit about intimate partner violence generally, and then talk about the factors that are leading to this uptake and this increase that I just described. So we know that why do men batter women? Men batter women because they learn it, because it works, and because they can. So what do I mean when I say they learn it? We live in a culture where social, economic, and cultural forces initiate men into using violence against women for the purposes of power and control. We know about, male privilege. We know about sexism. We know about patriarchy, and all of these forces are ultimately institutionalized in various, aspects of our culture and of our society. First and foremost, in the home that we're raised in, and then in, the institutions that young boys and young men participate in as we, move from boyhood into manhood. We see these standards of behavior reflected back to us in our uncles, our fathers, our coaches, our teachers, the ministers in the pulpit, the political leaders, the business leaders and the CEOs. It goes all the way across the breadth of our society. And so with that being said, the outcome of that is that we learn to use violence as a form of power and control, to ultimately, sort of force women into behaving the way that we want them to, or that we'd like them to. And what that ends up, creating is a whole host of victims. Obviously, the woman who's being abused, but in the context of families, the children who witness it. And, you know, more broadly, everyone that's connected to that woman and everyone that's connected to that family. You know, the teachers at the school have to contend with, you know, the pain and the hurt and the emotional suffering that the children endure. You know, the family members are oftentimes helpless, and they feel like they don't know what to do. They don't know what to say. They don't know how to rescue the person. And so it affects them as well. And then obviously, more broadly, you know, the larger society, in terms of the, you know, the economic costs of this violence and of this, of this epidemic, because we all bear the cost of it. You know, more broadly, we all bear the cost in people having to, you know, go to the hospital, the cost that the criminal justice system bears, the societal costs in terms of, you know, domestic violence being at the root of, you know, I think of it as the most pervasive form of trauma that people experience in this society. And we know that trauma is at the root of so many of the mental health disorders and conditions and, you know, challenges that people face as adults. It's like, you know, the developmental trauma or the trauma that they endured as children is the core of, you know, the kind of concerns that manifest once they become adults. And so, you know, with that sort of background, I just want to talk about why intimate partner violence is being, you know, impacted so seriously by COVID-19. So we know that isolation is probably the primary tactic that abusers use, you know, to try to gain control over the behavior of the victim. And given the current state of our society and the fact that we've all been asked to, you know, shelter in place, remain within our homes, you know, we're all experiencing a form of social isolation. We've been cut off from our family, our friends, our normal sources of support and encouragement and friendship, and all the kinds of things that a victim would want to turn to during, you know, a bad episode. The people that, you know, she would, you know, usually reach out to, or the places that she would go to receive respite or a place to retreat to, those have been cut off from her. And so, you know, with COVID-19 imposing this kind of isolation on the whole society, it would, you know, it would be, you know, it would stand to reason that women who are in abusive homes at this moment, you know, are especially vulnerable to, you know, the worst aspects of what isolation does to a person. It sort of engenders feelings of hopelessness and helplessness and despair because there's no place to escape to. So with that being, you know, the case, you know, again, we know people don't have access to the workplace, to family, to friends, to their social capital, you know, and social capital is, you know, the notion that, you know, we all have a set of resources available to us that comes by way of our relationships with others, people that we can depend on, people that we can count on, people that we can turn to in our times of need. And so the next factor that I want to highlight is stress. And I think Dr. Jordan was a previous speaker, and so she gave a great you know, outline of how stress impacts us. And so I just want you to think, you know, about stress in the context of intimate partner violence and COVID-19. So studies have shown that there's an increased rate of intimate partner violence after natural disasters and other crises that occur in our society. So take Hurricane Harvey, Hurricane Katrina, you know, the fires that swept across California last year, any of those kinds of catastrophic natural disasters that occur. You know, studies have found that in the aftermath of those, there are increased rates of intimate partner violence, which, you know, given the extreme amount of stress that people face during those events, you know, the abuser is, you know, in a situation where, again, you know, the imperative is to sort of reassert that dominance and power and control over the victim. And so, you know, right now during COVID-19, people are in a constant state of hypervigilance because the greatest source of stress right now is uncertainty. So if you take a natural disaster or any other sort of crisis, typical crisis, there's a beginning, there's a middle, and there's an end. And so we can sort of see our way through, you know, we can see the light at the end of the tunnel, you know, metaphorically. And so with this moment that we're all enduring, and I think the first speaker, Dr. Bibar, said, you know, we're experiencing a form of collective trauma. You know, we're all in a moment of uncertainty that we've never experienced before in our lives. And we don't know when it's going to end or how it's going to end. We don't know if there will be a return to normal, and we don't even know what the new normal will be. And so that level of anxiety creates, you know, acute stress in a household and in all of us as individuals. And we know that elevations in stress create an elevation in the hormones associated with stress, adrenaline and cortisol. And those two hormones flood our system, activate our sympathetic nervous system, cause us to go into fight or flight. And also, you know, it's associated with an increase in aggression and violence. Because when we're in that fight or flight state perpetually, you know, we don't come into a state of relaxation, and we can't think, we can't reason, we can't access our thinking brain. We're operating out of our emotional brain. We're operating out of our reptilian brain, the most primitive aspects of who we are, and the most primitive, you know, functions within our brain. And so people are on edge, you know, and people are easily triggered to, you know, to violence. And then the third factor that I want to talk about is the economic anxiety that's caused by 40 million Americans being unemployed. You know, millions of people are unemployed, and millions of people are also worried about losing their jobs at some point in the near future. Again, because of the pervasive sense of uncertainty. And so we know that intimate partner violence is also directly linked to economic distress. You know, homes that are economically distressed and poorly resourced are often the site of intimate partner violence. Because going back to Maslow's hierarchy of needs, you know, if safety, security, and stability aren't present, which is the base of, you know, Maslow's hierarchy, if those needs aren't met, and when those needs aren't met, rather than people turning towards each other, people tend to turn on each other because, you know, it's sort of a scramble for basic survival. And so, you know, again, with COVID-19, you know, creating this unprecedented level of unemployment, right? So we're seeing rates of unemployment that are comparable to the Great Depression. And we haven't seen these rates of unemployment in 60 years. And, you know, the government doesn't have a whole lot of answers for people. States and local municipalities are overwhelmed with the number of people who are seeking services and seeking support. You know, we know that we've all seen the media reports of backlogs of millions of people who have filed claims that have not been answered. And so every day that, you know, that unemployment claim goes unanswered, the level of stress increases exponentially in the home of the person who's the breadwinner, or who was formerly the breadwinner, or who was formerly the provider. And so back to why men batter, we know that, you know, masculinity is directly tied to our identity as providers and as the breadwinner in our culture. And so if the father, the husband, the boyfriend has lost his job, you know, that has a direct impact on his sense of self, his sense of manhood. It's under threat. And to sort of discharge that threat, men often turn to seeking to gain control and power over their female partner. And then finally, drugs and alcohol. So what do we do when we're stressed? We seek to self-medicate. We seek to find ways to cope. And of course, we know the rates of addiction and substance abuse in our society was also at an epidemic high. It was also an epidemic and at an all-time high prior to COVID-19 occurring. And so with this pandemic, coming into being, rates of addiction and substance abuse will clearly be going up because people are scared and worried.
Excuse
anxious.
me, Ed.
Mm-hmm.
Pardon me just one moment. I do apologize for interrupting you. Your very vital information there, and I'm going to let you continue just a moment. But I just want to let you know that shortly we've got Dr. Basran coming up at about 1:30. And so we wanted to give you all the following 8 minutes to continue on and then we can prepare for Dr. Basran. So if you all can go on for about the next 7 or 8 minutes, and then unfortunately, we'll have to conclude a little bit quicker than we thought for the domestic violence segment, but please.
No problem. I'll continue with that. I think that's a great place to stop.
Let's talk about what providers now can do about this. I mean, it was shocking to me that liquor stores were, for instance, open during the I think they never closed. Speaking of alcohol, what providers do besides listen without judgment, which is such a critical skill that we have as clinicians?
I think I want to point out that in the District of Columbia, there are a number of resources available, right, for victims. And I'm on the website now. There's a coronavirus resources for survivors website that's set up by the DC Coalition against domestic violence. And so that's a great resource. I think that would be the first place that I would start. So as a clinician myself in private practice, if I were seeing a client who came to me and said that she was in this situation, that's where I would start, by directing her to that website, going through it with her, helping her to become aware of all of the resources that are still available in the district. Shelters are still operating. All the DV agencies that provide support to women are still operating. So that's important to know. That even though we're facing this crisis, those organizations are still up and running.
I was also thinking about how you described it's oftentimes multi-generational. Mm-hmm. On both ends. There are so many similarities from in both partners' lives, frankly, and you and I have both worked with the survivors and the people who horrifically they feel so badly for what they're doing and didn't want to be abusive to their partners. It's really the last thing that most want to be. So how do you think other people can, clinicians can respond to what's going on in the household? Because we haven't stopped working.
I think that, let's see, how can clinicians respond? I think by, so it depends on who the clinician's working with. So if the clinician is working with the abusive, partner, there's a different response than the one that they would be using to work with the victim. So I'm going to talk about the abuser, because that's a lot of the work that I've done. I've facilitated batterer intervention groups with male batterers. And the one thing that I recognize in doing that work is that most people see them as sort of irredeemable monsters. We kind of think of them in our culture as people who, the violence that they use is some sort of inherent trait of their personality or of who they are. And so by explaining to them this process that I talked about, that we learn to do this, and if we learned it, we can unlearn it. And how do we unlearn it? We unlearn it when we're in a space where we're seen, where we're heard, where our own childhood trauma and developmental trauma is validated, normalized, and named for me. And so when I did that work with these men, many of them, you know, said like, look, I've never actually sat in a circle with other men to even talk about how I learned what manhood is, how I learned how to behave in a relationship. And so we have to create safe spaces for these men to actually engage in that conversation and to hear that you don't have to subscribe to the dominant view of masculinity. There is an alternative. But if you've never been in a space where you could even entertain the idea that there's an alternative, then you haven't given it any consideration. And so I'd say that creating safe spaces for these men to, you know, to address their own histories of trauma, their own histories of, you know, how they learned to behave the way that they do is the most important thing that I can think of.
And I think
Because I'm sorry, because there are spaces for the female victims. There are lots of spaces for them, but there are very few for the male perpetrator, if you will.
And during this pandemic, very quickly, as we need to wrap up, I mean, it's taking walks, it's finding beauty in the environment, it's taking hikes, it's doing exercises at home because the gyms are not open. It's somewhat what Dr. Jordan was saying about meditation.
Yes.
It's finding your, as you say, your own space, finding what brings you relaxation besides, of course, alcohol and other drugs.
Absolutely. All the things that Dr. Jordan pointed out that are the, you know, the positive ways that we learn to cope with stress are critically important for all of us at this time. And especially, you know, in homes like the ones that we've been talking about where, you know, people are just under unbearable levels of stress. And so, you know, deep breathing, meditation, exercise, making sure that you're getting adequate rest, you know, drinking plenty of water. I mean, just going back to the basics, self-care, making sure that you're prioritizing self-care is the most important thing that we can do to kind of neutralize that toxic stress that people are under.
And keeping music in your life.
Absolutely. Lots of music, walking, sunshine, you know, connections with friends and family, doing everything that we can to, you know, maintain our social capital, maintain our social connections, because, you know, ultimately that's the antidote in my mind. You know, that's the vaccine against the virus of violence, connections to other people.
Betsy Bibin and Ed McCurdy, if that's okay with you, we're gonna pause right there for domestic violence. Vital insights. And I had never heard anyone speak about the ability to redeem abusers in the way that you just talked about it via the use of safe spaces. So thank you very much for that very hopeful insight and very helpful insight. And to both of you, thank you for joining this conversation today. You certainly have added to our community resilience. At this time, we're going to continue the discussion, and we are going to call back, we're going to call back Will Bonnet to introduce Dr. Barbara Basram.
You know,
are you there?
Yes, I'm right here. I am actually delighted. I've been working in this field since 1989. And I have watched, you know, administrators from APRA and Department of Mental Health and now the Department of Behavioral Health come and go. And I don't know that I've ever been this excited or enthused because of Dr. Basram's leadership. The fact of the matter is she's gone out to the community to do listening sessions. She understands the importance of what's happening at the ground level. And we need that type of leadership. We need that type of support. I can't tell you how lucky I am to work in a field that is so emotionally gratifying. And I love the fact that, you know, Dr. Basram's driving the car. Without any further ado, I'm going to turn it over to Dr. Barbara Basram.
Yeah.
Okay. Good morning, everyone. I am really, good afternoon, I should say. I'm really delighted to be there. And thank you so much for those kind words. First of all, I think that all of you know that my approach to management is listening to the people who have the knowledge. And those are the people on the ground. Those are the people with lived experience. And those are the people who are out there doing the work. And I think we should take a moment really to pause and thank all of those frontline behavioral health workers that are out there in the field. We have seen many tributes to the physical health members, and I think it's very, very, very justified. But also, don't forget that all of our core service agencies and our substance use providers, our community response teams, our crisis workers, as well as our government operations have been open throughout this entire pandemic to make sure that people get the services that they need. I want to emphasize the fact that somebody said earlier, and that is the behavioral health care is health care. Mind, body, and spirit. Those three things are inextricably connected. And so we have to take care of our mental health, or mind our mental health, in the same way we take care of our physical health. So we got to break the stigma and make sure that we get those services. What I'd like to do today is I'd like to really share with you what the current health landscape really looks like as we move to hope and healing. We are moving to hope and healing. And first of all, this is what we're seeing. There's an emotional response to everything that's happening. I'm feeling it, you're feeling it. People are feeling lonely and isolated. I mean, I have been in my house by myself since March 11th. And I think many of you have probably had that same experience. And so my interactions have all been virtual with people. You know, I have been very consistent in terms of the stay at home order and staying in home. Everybody has feelings of insecurity. Some of it has to do with, we don't know if we're going to have a job tomorrow because of all of the things that are closed down. We don't know if we're going to have a job because of the financial impact on our community. We know that the District of Columbia has seen a decrease in revenues of over $700 million. That's a lot of money. And that has impact, because think about what that means. Those are jobs, that's people's livelihood, and people, what we're finding is those who have never, ever worried about their livelihood are now beginning to worry, and I'll talk to you about that. Fear. We have this invisible thing out there. You know, we don't know the enemy. We don't see the enemy. There's this invisible thing called COVID. We know that we can get it by simply talking to people because of the droplets that can be transmitted. We know that we can get it by other kinds of close contacts. We know that we might be able to get it by having it picked up on other parts of our body and then putting our hands in our face. And so this is very different than anything that we have experienced. We don't have a vaccine, so people are afraid. People are afraid to leave their houses. They are afraid, and they're having difficulty predicting the future within this environment. We are all concerned about our survival now. And when I say survival, I don't mean just economic survival. I mean physical livelihood and physical survival. And we have seen, and as I will share in a moment, a lot of the impacts on survival. And then all of us are suffering some degree of grief and loss. We are working, as Dr. Bebout said earlier, with the Office of the Chief Medical Examiner. And our job is that as families pick up and claim the bodies of individuals who have died as a result of COVID-19, we are directly intervening to provide them with supports through our virtual family access center. This means helping them to stabilize and begin to think about grief and loss, connecting them to the services they need so that they get the support they need. And I have to tell you, I've read some of the responses from some of the family members, and some of the family members were saying, oh my God, I'm glad at least somebody cared enough to ask me how I'm feeling and provided me with some resources so that I can recover and I can move through this grief and loss. We have other things that are coming online. We have a $2 million grant from SAMHSA that's coming online that will help us address the grief and loss of not only individuals who have experienced the death of a relative, but also all of you out there who are working in the field, who are also impacted by this, who also need some supports. We got to provide support for our frontline workers, including and specifically our behavioral health care staff. We have to also address the needs of those individuals who have never, ever interfaced with the behavioral health care system for a whole variety of reasons, who now are suffering all of these things that we're sharing, and they need some supports. And then as well as the people who are within our system. Now, this is what the data shows. The data shows that before the pandemic, 25% of adults in the US experienced a depressed mood, 25%. Now, in the most recent study that was done by the US Census Bureau, what we have found that 50% of adults are experiencing some sort of depression. And one of the things to me that I think we have to keep our eye on is that this is really impacting our young people. The 18 to 29-year-olds, 42% of them are saying that they are depressed. 42%. And then we're seeing that contrast to the 79-year-olds, 70 to 79-year-olds, which are not experiencing or not sharing that they've experienced as much depression as others. And this was a very large household survey. The other thing I want to share with you is that the DC rate in terms of the number of people who are experiencing depressed moods, according to the survey, is 41%. Well, that's almost half of us. And that's something for us to pay attention to. The other thing we're seeing is that 23% of our poorest citizens, and those are people who are making under $25,000 a year, are uncontrollably worried every single day about their livelihood, every single day. Whereas those who make $150,000 or more are only worrying only 6% of those are having the same experience. Unfortunately, what we know, and we know this from the data, is 445 people within the District of Columbia have lost their lives, and 8,406 have screened positive, including you, Mr. Bonnet, and thank you for sharing your story. And this is our recent data. The thing that we need to keep our eye on is that these numbers are really disproportionate in terms of who is really dying from the virus. The majority of the individuals that are dying, 335 of these individuals' lives lost, are African American. 49 of them are Hispanic, 50 are Caucasian or white, and 7 are Asian. That has implications for what we need to do in terms of moving forward, in terms of our behavioral health framework and our behavioral health services. We gotta do it. We gotta reduce health disparities. And even more now, these data are just pointing out what the disparities have been. Also, people have lost their jobs in looking at the coronavirus.net.com.government site. We find that 105,452 people, 105,452 people have filed for unemployment compensation. Now remember, we have 700,000 people in this community, and a large majority of those have now filed for unemployment, and many are food challenged. This is the situation that we're in right now. And as somebody said earlier, we also are seeing an increase in both domestic abuse because people are cloistered in their homes, and also the sale of alcohol has been through the roof. We looked at some of the data in terms of opioid deaths also yesterday. And what we're finding is in January, there was a spike, but it's beginning to come down now during the past month, during February. And I think a part of that is because of the street outreach that's happening in the community by the teams that are out there. So I'm painting this picture so that we know what our context is. We got to move into action, and we got to provide some support. All of us have to take care of ourselves. We can't help others unless we ourselves are taken care of. And so I'm really pitching my message to those of you who are providers. We are the worst at getting support for ourselves. And so what do we need to do? And so I like to go through the 4 M's of mental health: movement, exercise. We got to take care of ourselves. I don't know how many of you are sitting in front of your computer screens for 8 or 12 hours a day and not getting up. I know I'm guilty of it, and I'm trying to build that into my schedule so that I get more exercise, because this is what I'm doing most of the time. The second thing that we have to do is think about something that you do really well. Like, for example, I mean, you might knit well. You might grow flowers well. Go out into your garden and do that. You might write poetry. Do something that's not related to your job, that gives you pleasure. Because all of us have to find those things that give us pleasure and use that to help us in terms of maintaining our own mental health. The other thing we have to do, and this is something next that I suggest for all of us, is to stay connected. And we ourselves need to talk about others about what we're feeling. We heard this morning Dr. Bebout talking about some of his experiences, and we heard other members of the panel talking about their experiences. We gotta talk to one another, and we have to let people know what we're feeling so that they can help us through this time, and we gotta stay connected. One of the things that Mayor Bowser suggested, and it's something that I've been doing, and that is that every week, try to connect with at least 5 people personally. Pick up the phone, do a well check on them, and say, how are you doing today? That's really important, that kind of connection. And it's a very simple thing that all of us can do. And then go back, please. And then the last one, the 4th one, is one that one of the former speakers talked about, and that's mindfulness. That's meditation, doing relaxing activities. And we have to be creative about this now. I've heard a couple of things that people are doing. Like I know that some friends of mine actually did a dance party on using FaceTime. So everybody put on music, they all danced, they all, had hors d'oeuvres together, they all had a great time. And so you can do that. I know neighbors who have gathered at the foot of their driveways or outside their homes, maintaining social distance, and so that they could talk to each other, and so that they could share some joy together. And in one instance, one of the sororities had a cupcake activity where all of the sorors drove to the one location. They all had cupcakes, they ate them together, and they had an opportunity just to really, from their cars, talk and see each other. These seem like simple things, but they're very important in terms of us managing our mental health. Next slide, please. All of these things, next slide, is to help us build resilience. Resiliency is the key. We can bounce back and we will bounce back. So, as I said before, do something that gives you joy, establish a routine, and I think somebody talked about that before, and that is every morning, I actually print off a calendar and I write down what I'm gonna do during the day. I have a beginning and an ending to my day. I know when I'm gonna have meals. Schedule time for family time. Your families need you. I do mine virtually. I call my mom and my brother on the phone at a particular time every day so that I can maintain that relationship with them and I can have my family time. Meals are important. So please make sure you do that. And then the other thing is we have to have a little compassion right now. I mean, everybody is stressed. People are a little brittle. People may be a little short. And so let's be compassionate. Let's be understanding. Let's reach out if you hear that. Let's ask the question, how can I be supportive to you? You sound like you're a little on edge today. And also, you know, make sure that you not only reach out to somebody who feels alone, but just reach back and help them, and then do the same for yourself. And keep in touch, and here again, be mindful. It helps to stay in the present. Stay in the present. Because when you begin to think about what's going to happen next year and so on, it creates additional anxiety. So if we can stay in the present, you can manage what's happening right now, and it helps you manage the uncertainty related to the pandemic. We are in a state of anomie. We need to put some boundaries around it, and we need to help organize that. And this will help us to build the resilience that we need as we move forward. Now, if none of this works, what can you do? If I'm really feeling depressed, I can't bounce back, I really need some additional support. So next slide, please. Get some help. And I think that this is really, really important. We have early on in the pandemic, we put together a mental health hotline at our Access Helpline site. It operates 24/7, and the phones are being answered by clinicians. And those clinicians can help people stabilize and can connect you directly to care. We realize that the times when you're feeling lonely, the times when you're concerned, don't necessarily happen between 9 and 5. Typically, it happens at 2 in the morning or 12 at night or at some other time. And so call the mental health hotline so that you can get the support that you need. And I think that the other thing to know is that we have 81 providers throughout the community. Providers are available in all 8 wards. People can either call Access Helpline through 1-888-793-4357, and that is 1-887-WE-HELP. Or you can walk in or call any of the providers, and those providers will can register you there, and they can help you meet your needs. Everyone is being very cautious. We are following all the health guidelines. We are masking ourselves. We are making sure that we maintain social distance. If we are sick, we are staying home. If we have, and then as you're going into these agencies, people are taking your temperature to make sure that you don't have a fever. The other thing to note is that we do have the community response team, which is out and about in the community. That is a part of our core team, and they can be reached at 202-673-6495. They are mobile, and those teams are comprised of both people with lived experience as well as clinicians. And so please know that they're out and about. Anthony Hall and his team have been literally working the streets throughout this pandemic. And then also we have 2 government-operated sites. You can walk into 35 K Street and get treated. And then for our youngest consumers, if you have in need of child services, you can also walk into our Howard Road site. Our school-based behavioral health clinicians are also certainly working every day. And so I was supposed to really be the final speaker. Next slide, please. But because of my schedule, I had to go a little bit out of sync. And one of the things that I want to say to you as providers out there, your work matters. Self-care, care for the people that we are working with. Your work matters. And so please take care of yourself. Please move to resilience, and please have a wonderful rest of the day. Thank you very much for having me, and I look forward to our continued work together.
Dr. Bajwan, we thank you so much for all of the great information, the great data, as well as the resources that you provided. Tips on mindfulness, very, very helpful, that we need to be mindful about caring for ourselves and looking after others as well in this time. We thank you so much for all of your energy today.
You are very welcome. Unfortunately, I have to leave you now. Thank you all. Bye now.
All right. And so we're continuing with today's conversation around building community resilience. And we have a member of Resilience here with us, Will Bonnet, who mentioned earlier that he is a COVID overcomer. And so at some point that meant that he was tested. So coming to the microphone now to continue the conversation is Dr. Walter Forget, who is going to talk to us about testing and treatment. Just a few things about Dr. Forget's amazing list of credentials. He's a retired Air Force colonel and paratrooper, Speaker of the House of Delegates, member of the Board of Trustees on health policy, assistant professor of community and family medicine of Howard University School of Medicine, medical director, chief of health services administration, Department of Youth and Rehabilitation Services. Dr. Forget, we have unfortunately only about 5 minutes at this time, but we welcome all of the insights that you can pack into those precious moments. And we thank you for joining us.
Thank you for that. First, all praise and glory to God, from whom all blessings flow. And we're truly blessed to have the leadership of Dr. Bajwan. I was really inspired by her talk, also by Dr. Bibar sharing his experience. And I think at this point, we could show that first slide to put a face on the pandemic. We have lost some real icons. This is Dr. Elise Galati, whom a lot of you know. She was really a friend to so many. She was a professor of psychiatry at Howard University. More than that, she was a warrior, a Union Temple, and again, HIV/AIDS and substance abuse programs were her forte. So we truly miss her. I think if we could just now just take a moment of silent reflection as we really mourn the loss of 101,177 citizens, of which, as Dr. Bajwan said, 445 of our DC residents. We really have lost 5. At this time, we also mourn the loss of a 71-year-old grandmother shot in Southeast last week. And also let's pray for justice for the killing of George Floyd in Minneapolis. And I think at this point, I'm gonna take a point of personal privilege as the chaplain for DC Met Chi, of which Dr. Elise Galati was the president. She's the first African American woman to be president of the Med-Chi chapter of NMA. I think at this point, I can't tell you how impressed I've been with all the speakers. They really, I took notes and will be sharing with my physician colleagues as well. Because as Dr. Potash said, I had a couple of slides, but Dr. Potash from American Psychiatric Association made the statement that we really have a lot of changes in medication and all that during the pandemic, which reflect the stress that people are going under. But I think things that Dr. Jordan talked about, Ms. McCurdy, and Dr. Bajron, these are much better than any pills that we can produce. So I think, I hope the audience appreciates the behavioral change. As we know, if we wash our hands, wear a mask, social distancing, and get tested. And we're so blessed to have a mayor who really cares about the city, and with her and Dr. Bajron and the other leaders here in the city, Dr. Nesbitt, Health Department, we're moving into contact tracing. And now that we've had 12 days of decrease in incidence of COVID, we can anticipate reopening things safely. And we're so well served by our leadership in terms of the good data that we had to make policy, and the fact that we, on the downside of the curve, reflects the benefit of that leadership. I just want to close though with the word that love is the definition of God. Well, you can run those slides. We'll send this to the audience. These are just numbers from the district. Move, next slide. Next slide. Again, there's an article in the Wall Street Journal which documents the increase between January and March, which really complements what Dr. Bajron and Dr. Bibar were saying in terms of increased use of psychotropic drugs during this time. Again, I'm a liaison physician with Hillcrest Family Children's Center, one of the DBH core service agencies. And we have been open doing telepsychiatry during this whole time, and have been really available to our patients. One patient who was released from jail was COVID positive, was placed in the hotel. He's now doing well, and I think that really reflects the presence of DBH as represented by our agency. Let me just close by saying love is the definition of God. Although it's true that no one can exactly know how you feel about it, let's comfort some of the families that have lost loved ones to know that others care deeply. So every person you meet is fighting a difficult battle. Let those of us who have walked the path of grief reach out to help you along the way. And I think, I can't tell you, I guess we can use the scripture too, that anxiety weighs down the heart, but a kind word cheers it up. That's from Proverbs. Thank you so much for allowing me.
Thank you.
This time.
Dr. Forget, we appreciate that. We appreciate the words of scripture, and as well as your allowing us moments to reflect on those who have unfortunately perished, but giving them the honor that we do appreciate their journey, and we appreciate your words again. So thank you so much for sharing them. We're going to speak very quickly now to our closing, bringing on the CEO of Prestige Community Resources, John Smith. Also, there is a survey that is on the screen, and as you take that survey, you will need to scroll down. It's very simple to do, and once you have concluded the survey, please hit submit. And here for closing remarks for today's Community Resilience Program, we welcome CEO of Prestige Community Resources, John Smith.
All right, thank you so much, Seth, for moderating this event. And also, I want to thank all the speakers who actually take the time to join us in helping to build this community that we solely dearly loved. Thank you so much. I also want to thank those who actually put this together, and those who are working on the back end and the organizer. I want to thank you as well. Thank you so much. So as we know, and for those who receive our email, this is a 3 days event to honor and respect those who are going through mental illness in the month of May. So we got 2 more days to go. We got one event tomorrow. The first one in the morning is a food drive that we're going to be doing in the community. Then later in the evening, we have a motivational moment that will be starting at 5 o'clock. Then on Saturday, we have another event similar to this that we're going to be doing from 12 o'clock to 2 o'clock in the afternoon. So if you haven't registered for that event yet, please do, so that we can know how many people will be joining us on this event. So we're looking forward to you being part of this great community. I also want to kind of mention that this is just the first of many events we're having coming up in terms of how we can all build this community that's resilient to COVID-19. And we cannot do this by ourselves. So we rely on you, we rely on everyone to help us so that we can make this city, we can help the community to be resilient, so we can bounce back to our new normal, and we can continue to be a thriving part of the community. So I just want to thank you all, especially Dr. Basron, who will take our time to present to us, Dr. Bibot, and Dr. Jordan, and Dr. Faget, and all the folks who came to present at this event. So thank you so much. I truly appreciate your being here and supporting us. So I'm going to pass that on to Seth to wrap up so that we can close up this event. Thank you so much.
And those are closing words and remarks from the CEO of Prestige Community Resources, John Smith, regarding today's event in partnership with the DC Department of Behavioral Health and Prestige Community Resources, mental health awareness, building community resilience amid the COVID-19 pandemic. I think we all move away from this moment with greater understanding on how we can, like Will Bonnet, who is a COVID overcomer, that we can all deal with these moments of anxiety and or trauma better, and how we can also help others in our community to do the same. We had intended to do Q&A. If you sent your questions, particularly your request for materials, that still will be honored at this time. We do apologize for not being able to get to the Q&A as we had intended. We have just reached 2 p.m. We want to thank you all for joining us today. As Dr. Smith said, there will be 2 other events tomorrow and Saturday. We hope that you will join in, and we thank you for joining us today. My name is Seth Washington. It's been a pleasure being with you. To all of our speakers, Dr. Bibo, Dr. Basram, Mr. McCurdy, Ms. Biden, Dr. Forget, and as well as Will Bonnet and John Smith, and of course, to you. Thank you very much.